So tonight we're going to talk about upper extremities. And so anyone here can raise your hand if you have any kind of issues as far as with any of the upper extremities. So a lot of people like...
I can't raise my hand, my shoulder hurts too much.
That was a test. So a lot of times people like to know a little bit about statistics. So rotator cuff syndrome. It's in 88% of adults at some time in their life, from before they were 65 or even older, have experienced some sort of rotator cuff injury. So we're going to talk about the different types of a rotator cuff, because there's tendinitis, there's tearing, there's inflammation, but we'll talk about that. And then tennis elbow. Actually, the name from tennis elbow, as you can see, 95% of tennis elbow cases, these people do not even play tennis. So it's just, these are all repetitive, from repetitive injuries, and I'll get further into that. And then carpal tunnel syndrome. If you can just flick your wrist if you have carpal tunnel, that's good. So there are many, many, many cases per year, which costs about $2 billion. Just carpal tunnel alone, surgeries are around $2 billion per year, which is amazing. So we're going to get started. Oh, did I just disconnect it?
Oops. There we go.
All right, so the upper extremities. So when we look at the upper extremities, we're looking at the shoulder, right here. Then we're going to be taking a look at the elbows, the wrists, the bones of the wrists, and even the fingers. Now what makes up the shoulder, the joint of the shoulder, is actually the scapula. And the scapula is a bone in the body that often becomes misaligned, and people don't even know about it, which is causing a lot of the problems people experience in their shoulders. So, first we're going to talk about some terminology and learning a little bit about human physiology and what occurs with the body when these misalignments occur. So, degenerative joint disease, people are familiar with that? Degenerative disc disease and osteoarthritis. All three of these have something in common. Does anybody have an idea?
Old age.
It doesn't even have to, but it is more upon older people.
Immune related?
Muscles or bones?
It is bones, it is joints. It is the deterioration and decay of joints. But as opposed to like rheumatoid arthritis or psoriatic arthritis, osteoarthritis, which falls under DDD, degenerative disc disease, is actually osteoarthritis that occurs to the spine, to the disc. And degenerative joint disease is the part of the spine in all joints. So it happens in elbows, hands, everywhere, degenerative joint disease. And they're all what we call a wear and tear arthritis. So when you look at the spine, each vertebra has 4 joints. There's 2 above, 2 below. When you open up that joint, there's a coating. It's called cartilage. It's kind of like a Teflon coating. And wherever bones come together, the bones are coated with that Teflon to allow frictionless movement. Then the body provides fluid in there to bring nourishment to that cartilage. And from the side, so that's the joint, degenerative joint disease. And then within the spine, degenerative disc disease is the disc. The disc is made up of collagen. You ever see a baseball? Anyone? Well, you take apart a baseball, it's full of all these strings and they're all wrapped around, and in the middle it's like a hard ball. So your disc is very similar. There's what they call collagen strands, and it's a matrix, so it's going in all these different directions, and then in the middle it's called the nucleus pulposus. It's a fluid-filled gel-like substance, and it actually acts like a ball bearing for our motion and movement. So each disc has that nucleus pulposus, and it's all supported by that collagen matrix. So when it comes to joints, joints and discs do not have their own blood supply. So for nutrition, they rely upon what's called imbibition. So I'm going to get to that. So what happens to joints? It does not matter what joint it is. It's knee joints, it's elbow joints, it's shoulder joints. All joints have that coating, that cartilage coating. And then inside it has, you've heard of bursa. Bursa is filled with synovial fluid. And what it does, it allows frictionless motion to occur within that joint so we can move around and not wear down that cartilage. So shoulders have it, elbows have it, your wrists have it, every bone, the bones in your feet have it, but between each bone in your hand, you have cartilage and there's fluid in there. Now bursa primarily are in shoulders, hips, elbows, and knees. It's usually the bigger joints that have the actual bursa, but there's also what we call joint capsules, which are very similar, just a smaller version. And that's what has that synovial fluid. So that's how cartilage is the only way it gets its nourishment, is from that synovial fluid, and inside the disc, the only way it gets its nourishment is from that fluid-filled gel-like substance called the nucleus pulposus. So what happens when they're shearing, it's going to be a reaction that occurs in the body. So the first thing that happens as it's shearing, it's almost very similar to if you go barefoot, you're going to start to build up blisters, and then eventually your body starts to lay down what's called the callus. But it's more like collagen and fibrinogen. It's a combination. So within the joint where that synovial fluid is, that cartilage, when you have shearing with a misaligned joint, part of that joint's going to move and create pressure. So if you have two bones, say this is the femur and this is a tibia, and they're coming together. Each bone has that cartilage, and then you have that fluid in between. So what happens is, say your tibia rotates outward, you're going to take pressure onto one part of that joint and not have as much pressure on the other side. So now it has pressure. As that person moves, they're going to create shearing and friction. So right away, the body's going to react to that quickly. It releases what's called lysosomes. Lysosomes are released just like fluid. When you're going barefoot and you start to build up a blister, lysosomes get released around that cartilage. Now your body wants to protect that. If lysosomes are allowed to continue to be released, what's going to happen is they're going to eat up that cartilage pretty quickly. So the body tries to protect it, and it lays down what's called fibrinogen. It's also called fibrotic tissue. It's like callus. So it's a more dense material. Now in muscles, when you strain a muscle, it's called collagen. So it lays down to try to repair and heal. But in joints, it's more fibrinogen, which is very dense. So fibrinogen, as long as that stress is there and that movement's going on, will continue to build up, build up, build up over time. What ends up happening, instead of that cartilage breaking down quickly within months, it allows that cartilage to last longer. And on average, from the time a bone shifts, it takes about 18 to 20 years of that friction going on before you start to see the breakdown of the cartilage. And when it comes to the discs, it's the same thing. You start to see the breakdown of the discs. So we see that on x-rays. So osteoarthritis, degenerative disc disease, and joint disease is all due to friction. Part of it, it's two equations, and then lack of nutrition. So we're going to get a little bit further into that. So here is any joint. You can see a good picture of it. So here's that synovial membrane. So this is any joint. This could be a finger joint. You have this is the capsule. Inside the capsule, you have synovial fluid. So when those bones shift or misalign and approximate, you're going to get that motion, that fluid. So physical shearing and friction produces what's called lysosomes, causing the production of fibrinogen. Imbibition is a great word, and what it means is it's the movement. So by movement, it pushes fluid out and pulls fluid in. So because cartilage and discs, all cartilage everywhere, does not get its own blood supply, it relies upon imbibition, that motion and movement, proper motion and movement through that joint, to be able to draw in the nutrients and push out the toxins. So if a joint shifts a little bit, it's not going to move properly. So on one side, you have that shearing going on the other, throughout that whole joint, you're getting lack of imbibition, so you're getting lack of nutrition to that joint. And again, that all falls under what we call osteoarthritis, which is DJD, and DJD happens can happen in every joint. And it's really just what we call it's a wearing down of that joint. Any questions so far?
if you improve your nutrition?
So nutrition, what you eat is always important, but even if you eat fantastic, and your amount of your free radicals compared to the amount of your antioxidants in your body are fighting off just regular cellular damage, even with that going on, if you don't have proper motion, it's still going to wear down that joint. So good nutrition is only going to help, but yes, to answer your question, yes. So there's different phases of degeneration that occur. There's actually 4 phases of degeneration. So I'll get to that, but yes, it's reversible. Phase 1 and 2 are reversible. You can come up and talk to you about this a good bit. All right, so here's the hand. This is in between the bones. So this happens everywhere. Happens with the radius and the ulna. Any joint this can occur to. So that's really the nutrition and the biomechanics of a joint. By keeping that joint healthy, you want proper alignment and motion going on in there. Does all that make sense? All right, so we're going to take a look at the biomechanics of the upper extremities, the shoulder blade, the shoulder. So you have, here's the shoulder blade. It creates what's called the glenohumeral fossa, joint. Then you have your sternoclavicular joint at the sternum. And then you also have your AC joint, your acromioclavicular joint. And that's just in the shoulder girdle. So we'll start with that. So optimal mechanics, as we saw, and this is, your whole body is a kinetic chain. It starts from your feet to your knees, to your hips, all the way up your spine, into your shoulders, neck, arms and hands. When you are level, your bones are in what we call neutral position. They're in the best position they can be, so you're not creating those stresses into the joint. So joints, due to misalignment, will have a certain amount of stress in them, depending on how far that misalignment occurs. So from when we look at from behind, of course, we want level knees, level hips, level shoulders, no head tilt. And from the side, our ear should be above our shoulder above our hip above our knee, and our knee above our ankles. You see people over time doing this, increased curves in their low back. All these start to create stresses onto the joints and the discs. So here is distortions that can occur. So you look at this person, one hip's going to be higher than the other, and it's a kinetic chain going all the way up. They have head tilt, they have one shoulder that's lower, they have what's called an anteverted scapula. And I'll get into this because this is helping people in my practice. They always looked at the shoulder, so they moved the humerus back in the day when I was in school. Now with more research, they're finding it's more of the scapula shifting that's causing stress into the joints, onto the rotator cuff muscles, which is creating this damage. So you can see posture, the further away you go, the more stress you're going to put onto the spine. So when we look, there's called an open kinetic chain and a closed kinetic chain. The closed kinetic chain is your lower extremity. So because the ground holds you, you have that foundation, this is called, all going up here from your ankles, your knees to your hips is a closed kinetic chain. Because your upper extremities are more free moving and there's falls that can occur, this is called an open kinetic chain. There's more mobility, less stability, so more susceptibility to different misalignments and falls. Okay, so we'll take a look at the shoulder joint. So anybody here rotator cuff diagnosed? Rotator cuff, okay. Did they say you had tearing? How many tears? Did they say partial tears?
3 partial tears.
3? Okay. All right, so did you,
Candidate for reverse shoulder replacement.
okay,
That's the shoulder.
with partial. So do you have bone spurs and frozen shoulder? Okay.
Frozen shoulder.
On that one. All right, so we're going to talk about how this occurs. So bursitis is that inflammation of the bursa. Tendinitis is inflammation of the tendon. So when you look at, here's the joint, here's the scapula. I have one here so you can actually see it. But you have your scapula forms this glenoid fossa. Then you have your humeral head, which this is the cartilage. And then there's a joint here, a C joint. And then if you follow that across to your sternum, you have that joint here. So what happens is your shoulder blades, actually, let me just go back because this is a good picture. Your shoulder blades ideally should be like this. What happens is, and especially with mouse, people leaning forward all day long, they start to distort and the muscles start to change. So whatever we do on a regular basis, our body will start to conform. That's why posture is such a big thing. Over time, when people sit the same way, day after day after day, your muscles will start to change, which then causes your tendons to change, and the ligaments are what can connect bone to bone. So they're the most stabilizing part of a joint. So you have the ligaments, you have the tendon, which is the muscle, connects to the tendon, which then connects to the bone. And then you have our muscles. So here, when this shoulder rolls forward, and we're going to do a test on people now. If you have pain, you're not going, I don't want you to do it. But you can just try it to a degree. Just stop if you feel pain. But this shoulder, if this shoulder blade, typically it will go this way and forward. When that goes forward, your ability to raise your elbow will become limited because it creates stress into that joint. So if everybody would like to stand. So just first we'll just see where your shoulders are. So the first thing is if you have a bad shoulder, do the opposite shoulder. Now you're frozen on one, and so you don't have to do this, you can watch. So what you do is you put your hand on your shoulder and you just lightly bring up your chin and you just lift your elbow as high as you can. You gotta keep your hand on your shoulder.
Oh.
Good. So you're really limited, very, very, very limited. Okay, now compare it with your other one. You start and you go as high as you can. Good, good. You guys are pretty, did you feel a difference between the two?
Yeah, actually, I get one shoulder that is periodically sore and it's less mobile than the other one.
Yes.
Yeah.
So that's fibrinogen that lays down to the stresses and lack of motion and nutrients to that joint, and it creates adhesions. If they're there long enough, they become frozen. The more and more you build up, that fibrotic tissue doesn't allow that joint to move. And you're also laying down that fibrotic tissue onto nerves, which will also limit, your ability to move without pain. So did anyone really know, how was your left compared to your right?
It's good.
Okay, good. So now, just do a test. Now, in your good arm, the one that did work, just slightly bring your shoulders forward. Just kind of and then try to lift it. No, with your hand. Yep. So just bring it forward, the one you're going to try to lift, and try to lift it. See how far you can go. It just stops, right? You won't be able to lift it as far. What you've done is just physically brought your shoulder blade more forward, and it won't be able to go. So that's what happens. So your scapula, your shoulder blade, can actually shift on its own by many ways. It can happen due to your spinal curves, because of the way you have your spine and you have your shoulder blades coming and you have all these attachments. So when you look at the spine, you can see it if you like.
There.
So the shoulder blade sits about here. In between the shoulder blade and your spine, there's these muscles called the rhomboids. You also have muscles underneath called subscapular that come around. You've probably heard of the subscapular. You have your supraspinatus, your infraspinatus, and then you have what's called the teres minor. I'll go over that. And that all supports the shoulder joint to keep your shoulder in its socket. Now the rhomboids, if the spine is starting to shift, that's one of the causes that can cause that. It creates spasm, and it pulls on one side, and it causes the other side to adapt. So it pull on this side, and this side's going the other way. So there's a lot of different causes that cause the scapular shift. But when your scapula is shifted, That's what they're finding is causing more of the shoulder problems that are becoming misdiagnosed. So, when you look at the rotator cuff, as I mentioned, there's 4 different muscles. Your subscapularis, which is actually underneath your scapula, comes underneath your arm and attaches in the front. Then you have these muscles in the back, which come along and connect. So where it's white, those are ligaments. So it's muscle becomes ligament and then attaches to the bone. Now what happens when there's stresses, just like anywhere, so there's going to be stress on the joint because there's misalignment. There's going to be stress on these tendons because they're out of position and they're straining, they're working unequally. So what happens is with these strains, the body becomes inflamed at first. So just like inflammation in joints, your body starts to release what's called lysosomes. So with inflammation, your body's releasing this because there's stress. Now your body will start to lay down repair, which is mostly collagen around here. But if the stress becomes too strong and you're not getting enough nutrition and movement, it deteriorates. That tissue will deteriorate, the cartilage starts to deteriorate, and then it becomes weakened. And then the weaker it is, the tear, unless you had a major fall, and I'm going to go over that. So you can have, we'll get to that. So biomechanical stretchers affecting one or more of the 4 muscles, and then that creates weakness and then eventual tearing. So there's 2 ways this can happen. You can have what's called a macrotrauma, which is like a fall or an injury, or a microtrauma. A microtrauma is posture. It's what you do day in, day out. Holding a mouse like this day after day after day, you're going to start to create change. So it's very big. Ergonomics. I mean, it's been out for a while. I'd say at least 12 years. Ergonomics is making sure your workspace is good. So your head's not down. You have to have your monitor at a certain level, and I go over that at the end of the night. But people working on laptops all the time, constantly looking down, doing that day in, day out, those are microtraumas. So bursitis, again, it's creating stress on this bursa, the misalignment. It causes inflammation, and then that can lead towards deterioration and degeneration of the bursa. It's, as I mentioned, it can either be a high impact or an overuse syndrome occurs from bursitis. So tendinitis, same thing. It's the tendon, it's under a lot of strain, becomes inflamed, starts to build up, and then can eventually tear. Okay, any questions on the shoulder? I want to talk a little bit more about that later on, but any questions directly right now? Okay. Oh.
Sorry. Accidents or trauma or injury can cause, I think I was told years ago, fluid to leak from the muscles, which also causes adhesions.
Well, inflammation. Well, so if you inflame or you tear, but I mean, you can, a bed injury, if you break open a blood vessel, that's something different. But leakage, so muscles themselves, every time you work out, your body is called metabolic waste. So whenever you work out, your muscles are going to release what's called hyaluronic acid, carbon dioxide, and one more. It's the easiest one, lactic acid. So lactic acid, hyaluronic acid, and carbon dioxide is a natural metabolic waste of the muscle. So with an injury, it's possible you might have released a lot. So I'm not sure what he's saying, because it doesn't just leak. Those are the substances that it will produce.
So an injury,
Other than inflammation.
An injury itself won't cause your muscles to, or a torn muscle or whatever, won't cause your muscle to leak fluid.
It'll leak some of that lactic acid and hyaluronic acid, but it's, what happens is that tearing, the body starts to lay down that collagen and tries to repair it.
That's the fibrinogen you're talking about.
So fibrinogen is more, lays down in joints, it's more collagen that lays down in soft tissue.
So soft tissue
Muscles.
collagen, what about fascia? How's that affected with accidents and injuries?
You can tear fascia.
That gets
Fascia
torn
is-
easily, I think, doesn't it?
Yeah, and that gets, there's nerve endings, and they don't heal properly, it inflames, and that's sensory nerves all along the fascia. So that's why people, so you have motor nerves, you have sensory nerves, depending on how you affect that. People can have degeneration going on in their spine and not affect the sensory part of the nerve, and that joint can get into like a phase 3 and 4 before they ever feel pain. So, but fascia has lots of sensory, it's just a network of sensory nerves.
And that's probably why so many people that are diagnosed with fibromyalgia have had horrible accidents. I found out in treatments,
Yeah, so if they had
all
tearing.
that trauma.
Yep, if they had, so what happens is when you have an injury, if it doesn't heal right and it's in a bad position, there's constant stress going on in that area, and that's exactly what we're talking about tonight as far as how it affects the joints, and then also how it affects soft tissue with collagen, you lose range of motion. All right, so the elbow. Anyone here have elbow problems? Okay, so again, the elbow has a bursa, so this is called the olecranon, and it's part of your ulnar bone. So you have your humerus that comes down, you have your ulnar, and you have your radius. I didn't have a model, but maybe next time. So it's really an interesting joint because it's grooved to hold this olecranon, this part in there, and it's a hinge joint. But again, like all joints, it has cartilage, it has a bursa, it has that synovial fluid, and that's how a joint stays healthy. Then it has many, many muscle attachments because you can rotate. The only bones that rotate are here, your radius and your ulnar. But this, and then this radius is a little bone that just slightly shifts this way. It's a little head where it comes together with the ulna. Now your ulna is the bigger bone. It's really what connects to your humerus. So what can happen to the ulna is it can shift in or it can shift out in the joint, which creates stress on the joint. Okay, and then the radius head can also shift. So they talk about tennis elbow, that's this side, the lateral side. Golfer's elbow is this side, and the reason why with golfing, you tend to overuse and create strain to this part, and tennis, it's the backhand coming through that creates strain there. So that's how they came up with the name. And that's a tendinitis. So there's lateral epicondylitis, which affects, again, that's tennis elbow. And then you have medial epicondylitis, which is golfer's elbow. So again, it's overuse, but also misalignment will occur. So I've had patients come in who are golfers, we'll check to see if the tendon's off, but we want to find out what's causing that tendinitis. Is it just overuse, or is that joint in a bad position creating more tension and strain on that tendon? So we see that actually a lot. Here's the golfer's elbow, the medial epicondylitis, inflammation. It starts that whole cascading effect that eventually can start to wear down the joint itself. Okay, so anybody have any questions?
Cubital tunnel syndrome.
Cubital
What
tunnel.
causes that?
That's where the nerve passes through the part of, and it becomes pressure on that nerve. So it can happen from the muscle, it can happen from inflammation, it can, so those are typically what puts pressure on there. So the goal is find out why, like why all of a sudden do you have that? So if you had a fall, it makes sense. But if you have it where it just accumulated over a period of time, it's a good chance that it would happen. It's been shifting over time, creating that strain and that stress, and that whole cascading effect has been occurring around that joint with the lysosomes and then eventually the collagen and the fibrinogen.
I get my elbows adjusted all the time, but it does not resolve that nerve pain into my finger.
Okay, so you can have, so often, if you have your elbow, if your wrist, it's a kinetic chain, if your wrist is off, it can affect the radius, so it doesn't really affect this, it doesn't help that joint to settle properly. So when they're checking your elbow, they should also be checking your wrist.
He does.
Okay. So other things, habits can also cause it. Or it can be in a stage that it's just so aggravated. So I talk about the different phases of degeneration. If that joint's been wearing down pretty badly, it's hard to bring that back. Or you can also get what's called laser. There's different therapies you can do to help those cells to regenerate. Okay, so we're going to go on to the wrist, which is good timing. So carpal tunnel. So when you look at the wrist through here, you have all these tendons, you have arteries, and you have veins and nerves that come through this opening right through here. So this would be if your hand was up like this. So as you can feel, these are the tendons. So there's the median nerve, and this is called the retinaculum sheath. And what happens is when you entrap that nerve and/or blood vessels, you get numbness and tingling. So sometimes just the lack of blood flow causes numbness, but there's also the sensory part of the nerve. It's called the vibratory portion of the nerve. You put pressure on that, you'll also get numbness. And if you hit the pain portion of the nerve, the sensory part of pain, you'll get pain. So the definition is that entrapment is the result either through the cross-sectional diameter of this becomes diminished, becomes tight, or the contents inside that creates inflammation and starts to swell into that nerve. So that's what true carpal tunnel is. Now, a lot of people will get surgeries where they cut this retinaculum sheath. There's a lot of research, not done by our profession, but there's follow-up research that says, okay, this may or may not help in the beginning, but long-term, you create an instability, scar tissue lays down, and there's a higher percentage years later that instability has allowed things to start to shift. It's not holding things intact. So there's other things that can cause it. So there's 4 of the bones in your hand, which are called, you have your scaphoid, which is here, your lunate, your capitate, and your triquetrum. These bones, which are here, when they shift, and they do shift, if they shift in this way, they're going to compress that nerve and can cause carpal tunnel syndrome symptoms. So it's really going about to find out what's the cause with all of this. Anytime we see a patient in our office, what's causing your pain? But we know physiologically what will happen to joints and how they break down. We also know physiologically how bones can shift. And we know when a bone shifts, this is the biggest giveaway, is that joint won't move properly. The longer that joint has not been able to get its nutrition and it's laying down fibrinogen and fibrotic tissue, that joint will not, those 2 bones will not move well. So that's one of the ways that we check your joints, is to see what kind of motion and movement is going on there.
Now where are those bones on that?
On here?
Yeah.
So if you look here, this is your scaphoid, this is your lunate, this is your triquetrum, and this is your capitate. So it's these
And they're on the
bones.
top of your hand?
Well, they're on the bottom too. They
Oh,
go all the
okay.
way through.
Oh, okay.
So when they shift, depending, and typically what happens is your lunate will shift this way, causes this to come up, and it creates tension there. The scaphoid tends to roll when it does misalign this way, and the capitate also will shift in, like this. So
So it's right in here then?
it's right there, right at the wrist. So we check all the bones, because any bone can shift, but these, when someone comes in with carpal tunnel, we're checking those bones. Well, we're gonna check them all, but we're gonna focus right on there. And if it's moving well, we're gonna say, okay, it's not the bones. It could be this retinaculum sheath. But we wanna rule out if it is the bones before you get cut open. Okay. So there's not a whole lot to talk about the wrist, other than here's your ulna, here's your radius, they do shift. So to go back, like they just can shift and move out of position. So we check that. If it's not moving properly, we know there's stress on the joint. So to go back to the elbow, you should always check the elbow and the shoulder. You should always check the wrist and the shoulder above and below when you have problems with the elbow. So do they check your shoulder also? Yes.
Me? I'm sorry.
That's okay.
Oh yeah, they check everything.
Okay.
I mean, I've been going to chiropractors for 30 years.
Okay.
And I've had multiple accidents and injuries, and my chiropractor checks everything. But I'm finding that since I stopped specific treatment, myofascial release and craniosacral therapy, since I stopped all that, I'm in a lot worse shape. So I think a lot of my issues are related to restricted fascia and torn fascia from.
Well, something causes that to occur in the first, so your whole kinetic chain. So I'll be talking about lower extremities. The feet are huge. Your feet are such a big part. I've read research on patients that have gone to chiropractors 30 years, would continue to get adjusted, would have migraines. As long as they got adjusted, they felt fine. But if they missed their adjustments, attention just to biomechanics and the way their body had to compensate, the migraines would come back. And what ended up happening is the person's foot, they had broken down the arches, and I go over the different arches and how pronation occurs. But when pronation, your foot occurs, your tibia rotates out, your femur rotates in, causes your hip to drop, and that's that whole kinetic chain. Now, when we check the hips, that can come from the feet, it can come from the hips just shifting, or it can come from anatomically differences in legs.
I have that.
You do. Now, I'll talk about this more. I mean, it's really focused, but basically, you have to know one thing. As long as you have an anatomical difference of 5 millimeters or less, you just wear a heel lift. If you go above 5 millimeters, you need to have your whole shoe fixed, because otherwise it creates tension on your fascia of your foot. But if you're constantly off, your body is always trying to compensate for that.
Other chiropractors do not recommend heel lifts. I've gotten like some that say, yes, you need one, others that say, no, you don't need one.
They need to see the latest research, because there's stuff that's going out. There's a guy out that I actually work with, like I study on his stuff, and he works with a lot of professional athletes, tennis players, people, life career, like they just overtime overuse. And he says the biggest thing he has found, and he did a research study of over 6,000 patients, 92.2% of them had some sort of leg length discrepancy. And as long as it's 3 millimeters or more, that's enough of a leg discrepancy, that's enough to create biomechanical stresses that your body has to compensate
In the
for.
hips, but what causes fasciitis or the plantar fasciitis in your feet?
Feet, so I go over that. It's just
Go
like the
on.
hands.
I'll
You're here,
just
they're
have
wrong.
16.
I don't have a problem that, you know, you're not gonna
See,
cover.
just like your hands, you have bones in your feet and they break down. So people can get orthotics, but unless you break up the adhesions in between the bones, you will not be able to build up those arches again. So it's all research information, but it's just biomechanics. It comes straight down. It happens in all joints. Stress on joints releases those lysosomes. It's the whole cascading effect, but then your kinetic chain is your body adapting to what's going on. Then, and that's just part of it, then bad habits are the other part.
Does your fascia abnormally adjust to those problems?
Just like if the muscle's under tension and it's putting tension on the tendons, that fascia's going to could be getting torqued, so there's tension on the fascia.
I have never had as much relief from anything in my whole life as I have from myofascial release work.
That's good. I mean, that's what worked for you.
But I had to stop doing it. I can't afford it forever. It's very expensive.
So anytime you keep having to go over something again and again, there's an underlying cause. There's something else going on. Okay, so that's the wrist. So now we're going to look at causes. Now I talked about the kinetic chain coming up. That's just anatomy. That's making sure everything is as level as it can be. So I already actually covered this. You probably were looking through the notes being like, where is he? But macrotrauma. Only 2 to 5% of chronic problems come from macrotrauma. But macrotrauma, so falls, injuries, slipping on the ice, skiing, whatever, where you have high impact and causes the joints to shift. If they don't heal properly, you just start that whole effect. And the more damage you did, I mean, more damage, you're gonna start laying down calcium. So part of osteoarthritis, after about getting into your 18th, 20th year, you'll start to see, of that stress on the joint, you'll start to see bone spurs, which is calcium laying down around that. So macrotraumas. So the reason why I mention this is it's only 2 to 5%, but it happens. So unfortunately, you were in that percent from a bad injury. There's also, majority of the problems we see are things that are going on day in, day out. So statistically, researchers are saying, and it's not the chiropractic profession, these are people in this arena, 95 to 98% of the conditions are caused by what we do on a regular basis. We're going to take a look at some of these. So big purse syndrome, you're safe, I think, right?
Actually, I used to carry my briefcase on my left side.
All right.
I stopped and I got a backpack because I'm getting
Yeah.
a lot of pain in my left shoulder.
It's stresses, continual stresses. The way you sit on the couch, you want to relax, sit back. If you're doing that day in, day out, every night, it's going to start to change the structure. This is the biggest one. It's crazy. It's unbelievable. So when we check our patients, so we look at structure, we'll check their hips, and you know, you're a perfect example. When you come in, we're going to check your hip level, your shoulder blade level, your shoulder level, if you have head tilt, and then we feel your spine. And then once we see when the hips are on level, then we start seeing, okay, what's causing the hips? And that's why we do the foot scan. We do a laser scan on the bottom of the feet, which will measure your arches, how built up or falling down they start to occur. So once we see that someone's misaligned, then we take an x-ray because we want to objectively, we want to see structurally how their spine is settling. And when we take an x-ray, it's always with them standing because we want to see how gravity is settling with their joints. And we make sure when we take the x-ray, what's the biggest thing that I will say to a patient is stand what feels natural. Don't stand what feels proper because that's not how your spine's spending its time. So when we take the x-ray, we'll take the front view and we'll also take a lateral view. So I've been practicing 25 years now. Years ago, they didn't have cell phones. When I first started practicing, they had desktops. They had car phones, but they didn't have cell phones, and they weren't, it was rampant. And no kid even knew what, they saw their parents use a car phone, but that was about it. So, and then laptops weren't around either. So when I would do a lateral x-ray, I talked earlier, your ear should be above your shoulder, shoulder above your hip, hip above your knee, knee above your ankle. So it's called forward head tilt. So we measure that. So we measure off of C7, which is at the base, and that, your C1 should be above that. So we measure to see how far someone goes forward. Back in the day, 8 to 12 was high, 8 to 12 millimeters. On average, I'm seeing 28 millimeters of forward head tilt. 41, I've seen that's one of my highest. I've seen, so, and that's, the person has no idea, and they're not even older. We know as people age, what happens is these muscles start to shorten and they start to come forward. So these are young, these are kids, some of these are kids, and where's it coming from? Right here, tech neck. I mean, you look around everywhere, people are like this for hours. Like throughout the day, if you were to add up how often a kid's looking down like this, it's crazy. So structurally, they're creating change. So in the orthopedic world, the neurologists, chiropractors, it's called tech neck. And what they're going to see is they're going to have cervical degeneration in their neck at an earlier age because it takes 20 years on average of that stresses before you start to see degeneration. So from the time it's going to be, unless they start learning and changing, but they're not going to hold their phones up here. I mean, I have my own kids. I said, you're lucky because I keep adjusting you, but I'm going to get tired of it if you don't start listening because I want them to bring their phones up, but they don't. And then the other one is laptops. People are using laptops. It's convenient. I have a laptop, but when I'm at home, I have it on a stand, and I have just a keyboard, which is cheap, and a mouse. And it's so cheap, but now it's up where it belongs, so I'm looking like this instead of looking down for hours. So these are habits that occur, and this will affect the back, upper back. But the mouse is, most people have their arm out here. So when your arm's out here, that's one of the biggest causes of that shoulder. Now, as far as macro traumas causing the shoulder to go forward, is whenever you fall with your arm outstretched, that's the big one as far as a macro trauma. Your scapula, just from that injury, the way the muscles react to the trauma, end up pulling that shoulder forward, and then it heals like that. Okay. There's frozen shoulder and there's frozen. Okay. So, there's another cause. There's other causes. So, of course, there's a thing called the ballocks phenomenon. So you can irritate the nerves in a joint and the muscles here, and that can cause pain, but it'll also create a relay up to your neck. I'm going to talk real briefly about the nervous system. So you have your brain. Your brain coordinates and controls all function in your entire body. The only way your heart beats is through the coordination of the brain telling it to. And it does it through nerve tracts that come down the spinal cord. At each level, they stop, these nerve tracts, and then they, what's called resynapse right here, and it goes out to the rest of the body, and from there, they branch out all over the place. Each one of these nerves has over 100,000 individual nerve tracts on each side at each level. And when they come down within the spinal cord, they're protected by that fluid. And then it stops, and where it stops in resynapses is called a ganglion, nerve root ganglion. So each one has it all the way down on each side. Once you come off of that ganglion, it's called a peripheral nerve. So this is the central nerves, it stops, and then it becomes a peripheral nerve. Now the peripheral nerve is better protected. It has what's called a myelin sheath. So when researchers did studies on this, they applied pressure to it, and where the myelin was, it could withstand a good amount of pressure. When they came in and put pressure on that nerve root ganglion, and even before that, the weight of a dime, which was 8 to 10 millimeters of mercury pressure, affected the function of that nerve by 40% in 15 minutes. So that's why chiropractors, we do check the alignment. So some chiropractors just focus on the spine. Some also look at extremities, because I have found extremities will affect up into the spine. It's called the ballocks phenomenon. So if that's being irritated here, that can come up here, and when it resynapses, it's sending these messages which can cause misalignments here, which it's been researched. It's pretty wild how that happens. But then also posture can cause things to shift. So the other thing that can happen is you can put pressure on the nerve here, and it goes out, and it can affect the shoulder and cause those muscles not to work properly and support the joint properly. So it can go either way. So that's why we do check the alignment everywhere. We check the shoulders, we check the elbows, because we want everything in a neutral position to allow free neurologic flow back and forth. So a lot of the extremities issues can occur in the neck, and there's different levels. So out of each spinal nerve, you have 3 major portions to it. You have what's called a motor nerve portion, a sensory nerve portion, and an autonomic nerve portion. The autonomic nervous system is this part of the system that controls your blood vessels, your glands, and your organs. It's automatic. You never have to think about it. It's just your heart's beating, your food's digesting, your immune system's performing, it's reacting to the environment. That's the autonomic nervous system that controls all of that function, the bladder. Then you have your motor nerve function, which is all muscle function, and we can control that, of course. And then you have your sensory nerves, which we are only too aware of, our sensory nerves, but only 10% of each spinal nerve is for pain. You also have sensory nerves for touch. They're called vibratory nerves. So if you put pressure on the vibratory nerve, you're going to get numbness and tingling. You put pressure on a motor nerve, you can either get weakness going into that muscle, or if you irritate that nerve, it's called facilitation, it creates spasm. Same thing can happen to the autonomic nerve. You put pressure on the autonomic nerve, either you can slow down the performance going to that organ, that gland, or that blood vessel, or it's facilitation, you can cause it to overwork. So that organ, that gland, whatever, can overwork. So with chiropractors, we do focus on the spine because to us, that controls and coordinates all function. We just want to make sure those nerve channels are nice and open. So what causes those to diminish is rotation. So I don't know if anyone can see this, but that opening when the spine's in neutral, both sides will have a nice open channel. When the vertebra rotates to the opposite side, that'll narrow that opening, and it really doesn't even have to move far. And you see on an x-ray how far that misaligns. Lateral flexion, or a combination of both. And then that whole process, because now your stress on the joint, you're not having proper motion, you're not getting the nutrients to the cartilage, you're getting that friction to the cartilage, so it starts building up that fibrinogen and then eventually starts to break down. And the other way to diminish this opening is called stenosis. Stenosis occurs as you start to wear down the cartilage in the disc. That disc creates a nice opening this way. When that wears down, it becomes smaller. And you've probably heard of that word, stenosis. So as a person ages, by keeping your joints in proper alignment and allowing proper motion through every one of those joints, knees, elbows, that cartilage will age nicely. It will age a whole lot better than if there's stresses on those joints. So that's just a good way to help prevent having issues. So I demonstrated, but essentially this is a spinal cord. These are where the nerves come out. Here's a disc. This is a disc that's been injured. It started to weaken that collagen strands, and the nucleus pulposus starts to shift in this direction, puts pressure on the spinal cord and the nerve in this case. So on an x-ray, what that would look like, instead of having a nice forward curve in the neck, as this is coming in, that spine's coming back into that canal, you're going to narrow the opening where the nerves come through and also put pressure into the spinal cord. And you don't even have to feel it unless you hit the 10% of your nervous system, which is pain. And then there's another like 15%, which is the vibratory portion, which would be numbness and pain. Any questions so far? Is this interesting? Like, you guys find good? Now you can look up this in any human physiology book. It talks about cartilage, it talks about degeneration, it talks about imbibition. All that is found in what they teach in the schools. Okay. All right, so anyone here with the brachial plexus? Okay, so the brachial plexus is the certain parts of the cervical spine that branch off and form and create a big nerve that goes down into the arm. So C5 through T1 make up the brachial plexus. Where they go out to the different extremities. So when you have misalignment, you affect the nerve here. You could have neck issues. It goes to the shoulder, upper arm, forearm, hands and fingers. It's all part of that brachial plexus. Now there's specific areas that go to specific areas. So shoulder problems can come if you affect the nerves at C5 through C7 and T1 through T4. Elbow problems are C5 through T1, which are here, about here. And then wrist problems, branching out on both sides, are C4 through C7. So you have over 100,000 individual nerve tracts coming out at each one of these levels on each side. So that's why it covers an area. But basically, when a patient comes into our office, we're looking at two things. We're looking at position of their spine, and then when we check them, we're looking about motion. And then it all comes down to condition. So condition determines how long there's been stresses on those joints, because we know through lots and lots of research that, as I mentioned before, a misaligned vertebra or any joint creating that friction, it takes about 20 years before you start to see bone spurs and damage. Another 20 years, you're going to go on average. Now, all this can speed up due to the amount of trauma that a person withstands. So then you get into phase. So phase 1 is within 20 years. Phase 2 is 20 to 40 years. Phase 3 is getting beyond. It can get some repair, but it's limited. And phase 4 is the joint will actually break down the disc and everything where the bones fuse together. So when patients come to our office, well, if they're misaligned, we take the x-ray. If they're getting into 3/4 of the way through phase 2 and about 1/4 of the way through phase 3, we tell them we can bring things back a bit, but they'll never have what they used to. But you'll see disc spaces open on re-x-rays. And that's what we show. We'll show our patients as they start to open up. But we also, it's not just about adjustments and breaking up adhesions. I'll get to that a little bit later. It's about exercising, because you need to stretch muscles that have atrophied, especially with forward head tilt. You have so many muscles here that become shortened, and then these muscles overwork. When the scapula comes forward, it pulls down on what's called the levator scapula muscle, the rhomboids. It also hits serratus muscles. There's a lot of muscles that get involved. So it's about reestablishing, breaking up adhesions, that's what adjustments do, and then different stretches to stretch here, strengthen here. There's a subscapular stretch. There's different things you need to do to work with the soft tissue to get that to respond in the direction we're trying to realign things. So phase 1 is the easiest to correct, not that it's easy, but it's the easiest. Phase 2 is more difficult, because there's been more fibrotic tissue, more damage that's occurred over time. Any questions on that? Does that make sense?
The naming convention for the Cs and the Ts, are the
Oh.
Ts above the Cs, or the?
So Cs are for cervical. There's 7 of them. Sorry. I should-
Does the number increase going up or going down?
So C1
Okay.
through C7, and then it's T1 through T12, and that's your thoracic.
Okay.
And then lumbar are
L.
L's,
Oh.
L1, usually it's L5, but some people don't fuse their sacrum, so they have an L6. But, all right, so as I mentioned, it's about finding the cause. So when anyone comes in with a certain symptom and problem, we know where to look, but we're really just looking at 2 things: the movement, the position of that joint, the movement of that joint, and then the condition of the joint, as far as the cartilage or bone spurs. That lets us know if we can be effective. So is the problem just structural? Was it a fall of the shoulder blade, or the shoulder's misaligned, or the clavicle's been displaced? It's very common when the shoulder comes forward, the clavicle will go forward and drop. So you can work on this all the time, but if adhesions have built up here, unless you restore motion there, it's just gonna hold that out of position. Same thing with the elbows. You just work on the elbows, but you don't work down here to allow that proper movement back into that joint, it's not gonna hold. So if it's structural, if it's neurological, we talked about the spine. If it's misaligned, it's affecting the function of that nerve, controlling the muscles, or if it's both. And then, again, did we find it in time, or is it too late? What phase of degeneration is that joint in? Okay. So the way we determine that, with our feet, we do a scan of the bottom of your foot just to see from the ground up, literally, how things are going. So it measures your foot, your arch, and if you have any kind of pronation going on. We also motion. Well, first we check static, and then we motion. Motioning mostly goes on in the table. Every time we check a patient, once we determine if we can help them, we motion the vertebrae. And it's the vertebrae that aren't moving that we're reestablishing proper motion to. Posture, and then X-ray gives us all that information. So those are the 5 objective criteria we look at to see if we can help a person. Okay, so there's 3 steps to correct the cause. The big one is breaking habits, as we mentioned. A person sits the same way all the time. If they have shoulder problems, we'll break up adhesions, but it's only going to last as we break up the adhesions. If they keep doing the same thing, the adhesions will lay back down over time. We add specific exercises to work with the soft tissue to allow the joints to go back where they belong. And then, so I'll go over a few different stretches. Now these are pretty basic, but they're great, especially if you sit at a computer all day or at a desk all day. It's just, you can do this periodically throughout the day while you're at your desk. So you don't always have to stand, but if you would like to stand right now, you won't end up hitting the person beside you. So basically, it's, you will love these stretches. That's YWLT, you will love these. So that's a good way to remember. So yes, the first one is the Y, you just want to keep, the big thing is, so many times people like to stretch their neck like this. It's better when you do these stretches to have your head up because you're going to be squeezing. So you just Y, and you also kind of want to roll your shoulders back because so many people's shoulders roll forward. So you go Y, then you go into your W by pinching. The whole time you want to squeeze your shoulder blades together. You hold it for 20 seconds, and then you go into the W, and then you go into the L, and that's really good. And then you go into the T. So if you do about 5 of them, hold them for about, you can start off holding about 12, 15 seconds, but once you get going, hold them for 20 seconds, going through that 5 times while you're just sitting at your desk, you will help to offset what you're doing.
Would you please repeat that one more time, quick?
Yeah.
So it's Y, so just remember, you will love these.
Oh, okay.
So you make that Y, but
Y.
keep your head back and your shoulders squeezed. W, just bring the elbows down to make the W. Love, you go into the L. And then T, you come back up. And straight out. W, will, you gotta bend your elbows. Yeah.
No, you look like a W.
Love, and then you go down to your sides, and then these. Your head's not forced back, just relax back is good.
Thank you.
Now you can add it by kind of rolling your shoulders back, because that's going to help with the subscapular muscle. It comes underneath and attaches. So when we're doing this all day and this, that muscle gets shortened along with your pec minor muscle. When we talk about doorway stretches, a certain way we like to do doorway stretches. We hate when people do this, because you're creating a stress point here, and a stress point here. But if you just put the pressure into the doorway with your forearms, the only stress points here. Which
Well, my
you also want
numbness
to stretch.
stopped. I
What's
was
that?
sitting there doing the numbness thing, and by just doing that, it stopped. I swear.
No, I believe you. No, it's huge. There's thoracic outlet syndrome. Thoracic outlet syndrome is when your pecs, so you have a nerve and an artery that comes underneath your clavicle, and it impinges that. So if you're hitting blood vessels, you get that thoracic outlet numbness and tingling down in your arms and hands. So it's just stretching pec muscles that become shortened and tight. Just opening that up will help. But if your clavicle is also shifted, then you also need to reposition that clavicle. Okay, all right, so there's other ones as far as once you start to get, so the biggest thing is people who work out a lot, they can't wait to start working out again. We have to have them hold off a little bit because we're trying to create change of the structure, so if they're strengthening an area that we're trying to change, it just slows up the process. So we give these later on, but the wall angel's good. The wall angel, you can't go wrong there because everyone tends to be weak here because they're all coming forward. So wall angel, I like the, you will love these better, but the wall angel is you just get up and you just push against the wall, like that. Not your head, just your arms and your elbows. And then there's different, when you start strengthening, you lean down. But these are all more strengthening exercises. But there's different things you can do just to help offset what you do behind a computer.
Now, is
Or
there a
if you're sick.
website that lists these, or?
Honestly, there's so many exercises on the web that you can find anything you're looking for.
No, but I mean that has.
We don't
the
have-
IWLT or the.
You can, I don't know, I mean, we've kind of come up with this over time, so it's not like we got it, searched it.
I did just record it, and I'll put it up on our Facebook page, and you can go on there and find it.
Watch the
I
video.
know we're gonna have, the video's gonna be on YouTube as well, so you can watch the video and watch Dr. Jim do his
Oh,
stretches.
okay, so it
And
will be
then,
on YouTube
Yeah, I have to
then?
give that to my son. It'll be on
The
YouTube?
Phoenixville Library has a YouTube
Oh,
site.
and I can also
So
email
if
you
you look
the
up
link, so
on
you can
YouTube, just
download
look
it.
up Phoenixville
Put it
Library.
on your computer also, if you'd like.
Yeah. So then the last one is chiropractic adjustments are the only thing that really restore motion to a joint. So your spine is made up of many, many, many segments. So when you have a misalignment, those vertebrae aren't going to move properly, the ones that are misaligned. But what ends up happening is the ones above and below have to make up for that force, and they become hypermobile. So when people crack their necks, that cracking is just a release of gas. So that gas builds up inside that synovial fluid. So when that synovial fluid, so when you have misalignment, as I mentioned, you have bad mechanics as far as imbibition, you're not getting the nutrients right, but you're jamming one side and you're creating, and then you don't have stress, you create a gap on the other side. And that's that capsule, that synovial capsule, and there's fluids inside that. So as they're moving throughout the day, they're going to build up, and then the one that becomes hyper is going to build up gas also. And the joints that are going to move well are the ones that are hyper, the ones that aren't going to move. So when people do different stretches, the stretches will go to the hypermobile joint. They're not as specific to the two or whatever that can't move properly. So what chiropractors focus on is we're never going to adjust into a joint that moves properly. We're only going to adjust into the one that's not moving properly to break up the adhesions and restore motion so we can get its nutrients. So that's big, because that's a big thing that I try to, once we get going with our patients, we say try not to crack your own neck, because you're not doing any good. You're creating a more hypermobile above and below the actual fixated joint. So, all right, I think we're almost done. So yep, we're all done. So, yes.
I'm sorry, about the cracking,
Yeah.
if you like get a massage or something and you wake up and or not you wake up, I don't fall asleep. You get up and then your different things crack, is that bad?
No, that's okay. You're not
Oh,
forcing
okay.
a crack. So if you're just moving around and you hear like a release of gas, it's an indicator that things aren't lined up right.
Yeah, okay.
But it's not going to harm. I mean, it's just,
Okay.
it's not, it's the people that force the cracks and go, they're just affecting the hypermobile joints, and they're creating more instability above and below the joints.
My son does that all the time, and it drives me nuts, because I've been going to a chiropractor my whole life, and I'm like, please stop doing that.
Yeah.
So, other than chiropractic and doing some stretching, if you were treating a person like him, he's a 25-year-old who works in an office, so he spent all of his years in high school and college and now at work bending, over, and I can actually see, I can see his forward head, I can see his shoulders hunched over, I can see all these changes, and he keeps cracking his own neck. So I'm just wondering, I pretty much know what my chiropractor does. I just wanted to get an opinion, and that's why I'm here tonight. I like to hear from different chiropractors about all these things. So other than adjusting someone's neck and having them do some of these stretches, do you do massage, traction, electric stim,
Yeah.
any of these other
Um,
modalities?
So for years, I used to do electric
Manual
stim.
traction,
Well, part of my adjustment's manual traction. We also do intersegmental traction, where you lay on a table and it actually goes up and down your spine, and it works each vertebra, just induces
The roller.
motion. The roller beds.
Yeah, I know that.
Yeah, so there's different degrees of them, but I like the ones that can go pretty deep. When the patient, so it's a gradient. When patients start with us, have you been on? Yeah, so in the beginning, we go kind of light. We went about 2.5. Did we, or did we go up to 3? Level 3.
I don't know.
Okay, usually 2.5 is where we start somebody. And how did it feel?
Oh, it was great. It was
Okay,
like a
good.
massage.
'Cause it is, it's like a massage, because you're working the paraspinal muscles that are on each side of the spine. It's going to help the muscles, which build up lactic acid, but we really like it because it's getting motion into the
Yeah,
joints.
I do that.
So that's good, and then there's different levels, and it's a gradient. As the adhesions break up, then we start to improve the amount of pressure going into the spine. So yeah, we do intersegmental traction. I'm not a fan of electric stim.
I'm not either.
I've been practicing 25 years. I did it for about 12 years, and then a study that came out that said in a certain percentage of the cases, it actually made the muscle more tighter.
That's what it does to me.
So, and we would get that with patients, would come off before that study came out, and, I'm reacting like that's not what I'm supposed to do. So once I saw that study, I just took them off the shelves because it was irritating. So they said hot tacks are just as effective, if not more effective, than electric stim for calming the muscle.
Do you have a massage therapist?
We have one we refer to, she works with the Eagles, she's
Uh-huh.
awesome, her name's Amy Kraft, and we refer to her, we don't do it in office, because insurance is such a pain that it was such a hassle, but we refer to her and she's phenomenal. But she's real busy right now with the Eagles. And she is, I mean, but there's another one that we really like, her name's KB, we refer to her also, she's great. Yeah, I mean, that just helps so much.
I think that's really important. To me, massage and myofascial release are probably the two most,
I love sacral, depending on the
Craniosacral
condition,
work.
sacro-occipital. I mean, I do a form of sacro-occipital work, but I refer to the people that just specify on that, if you need that, depending on what's going on.
So oddly enough, one of the times that I think I tend to injure myself unconsciously is when I'm sleeping. So do you recommend like a certain posture, or I know I had a lot of problems because I had a bent pillow. Do you recommend like a certain style?
Yeah, that's a loaded question, but it's a good one. So, weight distribution as far as mattresses will change on different people. Some people are heavier in some areas than others, so some people might need a more firm mattress to support the overall body. Some people get away with a less supportive mattress because their weight is distributed more through. So that's always a question I get about mattress. So it really depends on where you carry your weight, if you want more firm mattress or not. Then when it comes to position, if you're going to lay on your back, you should put pillows underneath, the smaller your back. When you do that, if your legs are straight, you're going to end up increasing the arch in your low back. If you bend your knees, you end up, as the knees come up, the pelvis goes like this, and then you lessen the stress on your low back. As far as pillows, if you're laying on your back, you don't want the pillow that's pushing your head up, because then you're going to create tension and strain. So if you have a fairly high pillow, just get your back up higher on it, and then your head's not being pushed up. When it comes to your side, we like people to put a pillow between their knees so their legs don't rotate, because if you're in a position where you're rotated that whole night, you just create more stress, so it could get aggravated. So by putting a pillow in between your knees, you end up keeping your spine more in neutral, and we also suggest bending it, bending your knees. Again, it's going to flatten the back. It just creates less stress on the spine. As far as when you're on your side, we get people with, so another cause of that shoulder coming forward is when people lay on their shoulder and they sleep like this for hours, they stretch the
Yeah,
muscles,
That's what I do.
and it comes forward and they create stress in the here, create tension. So that's a tough call. We say, I mean, you fall asleep, you don't, but if you start off, if you're going to be on your side, it's good to put a pillow in front of you to kind of keep you from rolling. You can put a long pillow in front. Those are things that are helpful. But once you fall asleep, if you're a turner, I mean, you can only do the best you can at the onset, as you fall asleep. But those are things. And then the other thing with the pillow on your side is you don't want a pillow that's so flat that your head's down, and you don't want a pillow that's so fat that it's pushing your head up. So when your head is relaxed, you want your head just more closer to neutral. You don't want it down here, and you don't want it being pushed up here. Most of the time, people are pushing it up.
Yeah, see, that's what well, it's my left side that hurts. I got one of those long pillows.
Yeah.
And I put it up.
In front.
Well, no, I put it, and I lay on this side.
Okay, yeah.
And, so it's giving me, and
So
that.
you put it behind you.
Yeah.
Yeah, that's good support too.
So that's what I did, that's where I find I'm getting relief, because I sleep on my hands. And
Yeah, that's fine. That's not good.
See, that's my problem.
Yeah, so there are braces that keep it straighter.
Yeah, I did buy I went out and I bought braces to
You have,
try
if you're in a
and.
habit, so you can break that habit. So I just lean on my wife when I'm home, but then you never know what's going to happen. Get a massage.
So for people that have a desk job or they work in front of a computer most of the day, how often do you recommend getting up, like standing up?
Within an hour, I would stand up,
Right.
at least every hour. And people do it. I mean, some people say there's no way. Some people will put a timer on their computer to remind them to get up. and even if you don't, but what's better, which is awesome, and I don't know, a lot of people have heard about the Harvard study, and they talk about if you sit all day, your metabolism, all kinds of, but if you stand, it was better for your blood sugar, it was better for your cardiovascular. So they have those, what are they called?
Standing desks?
It's a standing desk, but they have two different models out there. And I have patients that switch, and they love them. And the ones that you can bring up and put back down, it's a great transition, and then eventually you can keep it up. I've had some patients that right away, they put it up and they loved it. I had other people that said they can only do it for, a little bit, and then they bring it back down, and they bring it back up. But even doing that, being on your feet is better. But the important thing is also, that goes along with it, is making sure wherever your mouse is, you're not up here, and you're not down here, you're here, where you're relaxed with your shoulders. That's where you don't want your mouse out here, you want your mouse closer, where you're just relaxing. And then your monitor, the middle of your monitor, when you look at it, should be an inch above eye level, is what they say is ideal. It just lessens the stressors, because people are still gonna have to look down at paperwork, but if you're looking up, you wanna be into a neutral. Yes?
I have arthritis in my thumbs. Is there anything that can be done?
So, osteoarthritis, if it's rheumatoid, it's an autoimmune disease where the antibodies are attacking the cartilage for an unknown reason. But, yeah, so what happens, fingers actually, and you're always told, don't crack your knuckles. But it's the way you move a joint that matters. So, joints. Yeah. So, joints, they're hinge joints, but they also rotate and move in the fingers, and this specifically. Now, you can get really broken down. So it depends, again, on what phase of degeneration. So we would x-ray, or you could bring in an x-ray of your hand, because if you're in a phase 3 and late 3, I do not want to aggravate that condition. I just want to help reestablish motion. So I don't do no harm. That's number one. But bone, so you can just check your own fingers. If your bone is, you should have a little bit of play lateral, and then also down. But the lateral one, and then tilt, you should be able to turn your fingers slightly. When they don't, there's a way that you just go the opposite direction. I mean, we're trained to do it, so there is a reason why we do it, but we do check that, and this is big. Your thumb that's a big one that gets adjusted, because that can rotate in, creates that rubbing, starts that whole cascading effect. It's been like that for years from overuse, just builds up calcification. But as long as it's in a phase 1 and 2, and even early phase 3, you can start to break that up. Now, all cells in your entire body are constantly dying and being replaced, every cell, even brain cells. You say brain cells weren't, well, studies came out, brain cells can regenerate. So, disc cells, cartilage cells are constantly dying and being replaced, but they can't be replaced when they're constantly being broken down, and that's what osteoarthritis is. They get broken down because they don't get the proper nutrition and they have stressors. So by removing the stress, those cells will regenerate. That's how phase 2, when we re-x-ray patients that have degeneration of their disc, they'll see that it's starting to open up as they go through their care. Plus, they're going to feel much more range of motion. Now, you just started, but how are you doing with your adjustments?
Fine, it feels better.
You feel more motion?
Mhm.
So that's fibrotic tissue. So when people in early stage start feeling better motion right away, that's that fibrotic tissue. It's starting to build up and allowing proper motion to the segments that weren't moving properly. Now, when patients are further along with degeneration, it's going to take longer to restore that motion. Okay. All right. I have for one more. Sorry. Wow, it's 8:25.
So do most insurances cover chiropractic care?
It all depends on your
You
plan.
talk to your insurance company.
Or you can call us, and if you call us and give the numbers, we always check on it anyway. So anytime a patient comes in, they bring their information, our front desk, they call, know your benefits, exactly how they cover.
I had no idea if mine was covered, and I just asked recently, and I didn't even have to get a referral, as long as they were in network, and then it's a $15 copay. I don't know how long it'll last.
Yeah, well, that should be on your sheet. Did they go, oh no, they're gonna, they didn't go over yours yet, your benefits with you?
Just at a high level.
Yeah, they're gonna go over the whole, everything. They'll have that probably for your next visit. Yes, one last
You do
question.
adjust fingers individually?
I do adjust fingers.
So if your fingers are arthritic and you get them adjusted, is there any relationship between osteoarthritis in the fingers and trigger finger?
Yes, there is, because you're creating tension onto that tendon. So it's more of the hands, the carpal bones are more involved with trigger finger, but also this joint here
The
is a big
middle
one.
one, yeah.
Yep, and that's your capitate, so that's one of the, that's a big.
So when you go to a hand doctor, they say you need surgery, which I had on this hand.
Depends on how bad it
It
is.
didn't work very well. Now he wants to do it on this hand.
Depends on how bad it is, if we can be effective. It's just like the amount of degeneration. If there's such buildup in that trigger, all I'm gonna do when a patient comes in is I'm gonna check the motion of those carpal bones and the joint. If it's not moving, and I know it's not like bone on bone, we're gonna start getting motion back in there. And then now your body can naturally start working the way it's supposed to.
I've never had any chiropractor check or adjust my fingers, ever.
Yeah, not all of them do it.
And now I have trigger finger going on in both hand, this hand and this middle finger, this thumb, and it's like, where is this coming from?
Yeah. Yeah. Well, thank you all very much for
Yeah.
coming.